And welcome. I'm Rebecca Broyles, co-owner educator for the Coding Corner Medical Coding Education. Today I want to talk about ASC coding mastery, building accuracy, compliance, and confidence in ambulatory surgery centers. We're going to take a deep dive into ASC coding, not just CPT code selection, but the operational and compliance context that makes ASC coding unique. We want to understand the ASC specific coding rules and reimbursement structure. We want to review common ASC procedures and coding pitfalls, apply correct modifier usage, strengthen documentation interpretation skills, and work through some real-world ASC case examples. What makes ASC coding unique? ASC coding is not the same as physician or hospital outpatient coding. Payment is tied to CMS-assigned groups, and many services are packaged. Coders must understand how CPT selection affects reimbursement and compliance. The ASC centers follow Medicare ASC payment system, or the ASCPS. Payment is based on the CPT code plus the ASC payment group. Device-intensive procedures have special payment rules. The ASC coding requires understanding of NCCI edits, status indicators, packaged services, and multiple procedure reductions. ASC payment basics. We have the ASC payment groups, or APGs, that determine reimbursement. The status indicator. They impact payment. For example, packaged items in are not separately reimbursed. A is for active, N is for packaged, J7 is for device intensive. These procedures require correct reporting of device HCPCS codes, and K are non-covered. The multiple procedure discount, you have the highest valued procedure paid at 100%, then the following goes down a percentage. ASC documentation must support both coding and regulatory compliance. Missing device documentation is a top risk audit. Documentation requirements. You need the procedure performed, the technique used, the laterality of the procedure, devices implanted or removed if applicable, start and stop times for anesthesia, and some payers require it for the actual procedures themselves, and you need to support medical necessity for the procedure. Each specialty has unique coding challenges. Examples we'll go over today will span several high-volume ASC specialties, such as orthopedics, gastroenterology, ophthalmology, pain management, podiatry, and general surgery. Modifier misuse is a major compliance risk. Provide payer-specific examples, especially for GI and ortho. The modifier essential tools for the ASC center include RT, LT for laterality, 50 for bilateral procedure, 59 XS or XU for distinct procedural service, 52 for reduced services, 53 for discontinued procedure, PT, screening colonoscopy converted to diagnostic for Medicare patients, and 33, preventative services for commercial payers. ASC coders must understand NCCI edits for arthroscopy. Many services are mutually exclusive or bundled. The orthopedic focus, some common ASC ortho procedures, the knee arthroscopy, 29881 and 29880, shoulder arthroscopies, 29822 through 29827, carpal tunnel release, 64721, and foot and ankle procedures. Arthroscopy codes follow strict bundling rules, and implants must be documented clearly if applicable. Ortho example cases. The knee arthroscopy, you have a partial medial meniscectomy. The CPT code would be 29881, and an option for the ICD-10 selection could be the meniscus tear code. Shoulder arthroscopy, we see a debridement and subarachnoid decompression. CPT code 29822 for the limited debridement and 29826 for the decompression. GI is one of the highest volume ASC specialties and one of the most audited. Colonoscopy hierarchy applies. EMR, ESD codes have higher reimbursement. ERCP and EUS require ductal and anatomic specificity. Modifiers PT and 33 are common in ASC GI coding. Some GI case examples, we have the screening colonoscopy and a snare polypectomy. The CPT code would be 45385. We would also add the modifier PT for a Medicare patient or 33 for a commercial to show the insurance company that the screening colonoscopy turned into a diagnostic. EGD with biopsy plus dilation. The CPT code 43239 for the biopsy and CPT code 43249 for the balloon dilation. For the colonoscopy example, the 45385 overrides any screening intent and why the biopsy was done. In the EGD, the biopsy and dilation are separately reportable. Pain management focus. Fluoroscopy is often bundled. Laterality is essential. Some common ASC pain procedures are epidural injections, facet joint injections, radiofrequency ablation, and SI joint injections. Imaging guidance is included for many pain procedures, but coders must know when it is separately billable. Some pain management case examples. We have a lumbar facet joint injection, bilateral L4 to L5, and L5 to S1. The CPT codes would be 64493 with a 50 modifier for the bilateral, and we would also use the add-on code of 64494 with the 50 modifier for the L5 through S1 area bilaterally. SI joint injection with fluoro. The CPT code would be 27096 as this code includes imaging. Device-intensive procedures in ASCs require reporting of device HCPCS codes. Device cost is built into payment. Missing device documentation will equal denials. Some common device-intensive ASC procedures include pacemaker or ICD generator changes, some ortho implant procedures, and certain ophthalmology procedures. The device documentation must include the manufacturer, model, and serial number. ASC compliance hotspots: incorrect modifier usage, missing device documentation, unbundling arthroscopy services, incorrect screening colonoscopy coding, and billing non-covered services. So stay proactive. A case study challenge: the ASC performed a right knee arthroscopy, a partial medial meniscectomy, chondroplasty of the patella, and synovectomy. In this case, we would use the NCCI bundling edits to see that the correct coding would be one code. That would be the 29881 for the meniscectomy. The chondroplasty and synovectomy are bundled into the meniscectomy code. Some key takeaways are ASC coding requires understanding of CPT, ASC payment rules, and NCCI edits. Documentation quality drives accuracy. Modifiers must be applied correctly. Device-intensive procedures require special attention, and when in doubt, query the provider. ASC coding is high stakes and requires both technical and clinical understanding. Thank you for joining me today. Please visit us at www.thecodingcornermce.com.